Greetings. My name's Dr. Njamba P. I'm an internal medicine specialist practicing at Chipata Central Hospital, Eastern Province in Zambia. Today I'm going to be running you through a clinical overview of differentiated thyroid carcinoma. So this is the outline of my presentation. Um, we'll discuss the introduction, risk factors, types, symptoms, and treatment. So thyroid carcinoma. Thyroid cancer accounts for approximately 1% of all malignancies. It's the fifth most common cancer globally among women, the female predominance of 3 to 1. Differentiated thyroid carcinoma includes papillary thyroid carcinoma, follicular, and oncocytic, which account for 90%, over 90% of all thyroid cancers. Other types of tumors that are included in the classification of differentiated thyroid carcinomas include the non-invasive follicular thyroid neoplasm with papillary-like nuclear features and the invasive incapsulated follicular variant of papillary thyroid carcinoma. These malignancies generally have excellent prognosis. Differentiated thyroid carcinoma implies that the tumor, which arises from follicular cells, has a similar structure to the thyroid, the follicular cells of the thyroid gland, and maintains some of the function that these follicular cells maintain, such as synthesis of thyroglobulin, for example, as well as expression of TSH receptors. So papillary thyroid carcinoma is the common among these types of tumors. It has an excellent prognosis. It is associated with BRAF mutations. Then follicular thyroid carcinoma is with RAS mutations. Then there's the oncocytic thyroid carcinomas. These have the classic oncocytic cells, which are essentially cells with increased number of mitochondria, and this gives the cells a classic eosinophilic appearance. Then the non-invasive follicular thyroid neoplasm with papillary-like neoplasm, NIFTP. These do not have or do not invade, do not have capsular or vascular invasion from the name, and they have a very low malignancy potential. Then the invasive encapsulated follicular variant of papillary thyroid carcinoma, indeed, these might have vascular or capsular invasion, and the nuclei of these type of tumors are similar to that of papillary thyroid carcinoma. What's described in literature for papillary thyroid carcinoma is that the nucleus under a microscope appear clear and have a ground glass appearance. So the following are the risk factors for thyroid carcinoma: history of specifically differentiated thyroid carcinoma, history of childhood neck and head radiation, total body radiation for bone marrow transplantation. This might be in patients being treated for leukemia, adult occupational radiation in low, moderate doses, for example, doctors working as radiologists. Obesity is also a risk factor for differentiated thyroid carcinoma, as well as a family history of thyroid cancer. Iodine deficiency is also a known risk factor, as well as female sex. Then thyroid disease, particularly Hashimoto's thyroiditis, which is essentially an autoimmune disease of the thyroid gland, which causes destruction of the thyroid with subsequent fibrosis and scarring of the thyroid and development of hypothyroidism. So such patients are at risk of developing differentiated thyroid cancer. So these are the types, like I have already alluded to, the papillary thyroid carcinoma, which is associated with the BRAF mutation. It spreads usually through lymph nodes, so such patients might present with lymphadenopathy, rarely gives distant mets. Follicular thyroid carcinoma spreads through blood, a hematogenous type of spread, and such patients might present with bone involvement or advanced disease. Then oncocytic thyroid carcinoma, these are the type of carcinoma which has the specific oncocytic cells, like I already mentioned, and the non-invasive follicular thyroid plasma papillary-like nuclear features. Some literature actually does not consider this to be malignancy, as there's no capsular or vascular invasion, and it rarely actually spreads and has an excellent prognosis. As we will see, even the treatment option is just a lobectomy, as opposed to total hemithyroidectomy, total thyroidectomy, and so on and so forth. And the invasive encapsulated follicular variant of papillary thyroid carcinoma has might have invasion of might have vascular or capsular invasion. However, the nuclei are similar to that of the papillary thyroid carcinoma. So the symptoms, patients might be symptomatic and just discover a thyroid mass or nodule for self-examination, or perhaps being seen for another medical condition, so a thyroid nodule might be discovered incidentally. In some circumstances, patient might present with neck pain. This is due to the fact that the tumor might spread to the nearby soft tissues, such as the muscles, the nerves, and this might result in neck pain. Cervical lymphadenopathy, enlargement of the cervical lymph nodes as a result of involvement of the lymph nodes, spread of the tumor to the lymph nodes. And there can be a change of voice, hoarseness or change of voice due to involvement of the recurrent laryngeal nerve. Then some patients might present with difficulty swallowing. They might present with dysphagia because of esophageal involvement, esophagus involvement, as well as difficulties breathing when the tumor invades the airway, particularly the trachea. Some patients, particularly those with follicular thyroid carcinoma, might present with bone pain. So the investigations for a patient with a suspected thyroid carcinoma as follows. Usually, I'll give it in the context of a patient who presents with an asymptomatic thyroid nodule. So the entry point for such patients usually would be to perform thyroid function tests. Usually, thyroid stimulating hormone is adequate. So if the TSH levels are high or normal, if they're high, they're suggestive of a hypofunctioning thyroid. And if they're normal, it essentially means that the thyroid is functioning well. Such patients are likely to have malignancy, and the next step would be to proceed to a neck ultrasound. In circumstances where the patient has a hyperfunctioning thyroid nodule, in such circumstances, the TSH levels would be low. Such patients would need a radioactive active iodine to further stratify them on the need for neck ultrasound and possible thyroid nodule biopsy. So for patients who have a normal TSH or a high TSH, as I already mentioned, to proceed to neck ultrasound, then neck ultrasound will help us stratify these patients to decide which patients will need fine needle aspiration biopsy. So there are two systems that are used. There's the TIRADS classification system for neck ultrasound, as well as the U classification. The TIRADS was developed by the American Thyroid Association. So the TIRADS was developed by the Americans. Then the U classification was developed by the British. So the TIRADS is performed by radiologists. It's more of a radiological type of stratification. There's a scoring system that is done, and based off the scoring system, patients are stratified on whether or not they will need biopsy. Usually, a scoring system of above 7 would entail that the patient will need fine needle aspiration biopsy. For the U classification, it's more descriptive, usually used by clinicians. So there will be different descriptions of the thyroid in regards to the echogenicity. For example, if a thyroid nodule is hypoechoic in relation to the thyroid tissue, and if there are calcifications and so on and so forth, which might signify malignancy, then such patients would need fine needle aspiration and biopsy. After the fine needle aspiration and biopsy is done, what is essentially done is there's a histology report is drawn from the biopsy from the after the fine needle aspiration has been done. A histology report is drawn, and different classification systems have been developed to guide treatment. So the two classification systems that are available are the Bethesda and the Thai classification. So the Thai classification which runs from 1 up to 5, will help guide treatment. For example, a patient that has a thyroid classification of 4, which implies suspicious for malignancy, would need hemithyroidectomy as the definite management plan, and so on and so forth. We're going to discuss more of that later. Other investigations that might be needed are the neck CT, computed tomography. Usually this is used for staging, as well as also the MRI might be used. Serum thyroglobulin and thyroglobulin antibodies are usually checked 6 weeks post-op and are not routinely done in patients with suspected thyroid carcinoma unless after total thyroidectomy. Then other investigations that might be considered in selected patients are germline investigations such as the PTN mutations for patients with suspected Corden syndrome. So like you notice now, the treatment of choice for differentiated thyroid carcinoma is surgery. So the types of surgery that are usually performed for such patients are a total thyroidectomy or a hemithyroidectomy, dependent on different factors. So total thyroidectomy is recommended for high-risk patients. So these are patients with a tumor size that's greater than 4 centimeters, or that have any of the following features, which are multifocal disease, bilateral disease, if there's extrathyroidal spread, familial disease, or presence of lymph node involvement or distant mets. If there's advanced disease or high risk for advanced disease, that is high risk patients, such patients will need a total thyroidectomy. Hemithyroidectomy may be considered in low risk patients. This might be a patient with a tumor size that is less than 4 centimeters, that is unilateral, with no extrathyroidal involvement, no lymph node involvement, and no distant mets. Then lymph node dissection is performed in patients with nodal involvement or in selected high-risk patients. So even in patients that do not have lymph node involvement but at high risk or high-risk patients, such patients would also need lymph node dissection. Then levothyroxine is started in patients after surgery, particularly those that underwent total thyroidectomy. So patients that underwent total thyroidectomy, levothyroxine is started to suppress thyroid-stimulating hormone levels. Levothyroxine might also be considered in patients post-operatively if cytology results show that the patient has high-risk features. For example, a low-risk patient who had maybe thyroidectomy done, but cytology results post-operatively show vascular involvement and micro extrathyroidal extension. Such patients might also be considered for levothyroxine. Another group of patients would be patients who, on subsequent follow-ups, have rise in levels of thyroglobulin or thyroglobulin antibodies. Such patients would also require levothyroxine. Then iodine ablation therapy is reserved for patients post-total thyroidectomy that are considered or deemed to be high risk. These might be patients with a tumor size that is above 4 centimeters, patients that had multifocal disease, bilateral disease, extrathyroidal spread, and so on and so forth. So it's not routinely done for all patients with differentiated thyroid carcinoma. Then thank you so much. Yeah. So essentially, that's what I had for you. Thank you. This is my list of references, and thank you very much.